Hello, and a warm welcome to this Bone Matters Extra session. This is a follow-on from the main Bone Matters session on hip fractures and recovering from a broken hip. And this is a brief session to expand on some of the issues raised, but also to draw on some personal experience of caring for someone with a hip fracture. I'm Viv, and I'm one of the specialist nurses here with the Royal Osteoporosis Society, and I'm joined by Julia. Julia, would you like to introduce yourself?
Yes, thanks, Viv. My name's Julia Thompson, and I manage the team of specialist nurses here at the Royal Osteoporosis Society. But I'm helping Viv with this Bone Matters Extra because I have recent personal experience of supporting somebody who's had a hip fracture. Sadly, at the beginning of December last year, my mum fell and broke her hip. So the family have very quickly had to adjust to supporting mum in the best way we can. And I thought I might have some experience which might be helpful for others who are going through a similar situation. Obviously, Viv, you've got more of a professional understanding and experience of this area. Tell us a little bit about that.
Yes. So I worked for many years as a orthopaedic trauma nurse, was a sister on the ward for some time. So had in that time worked and looked after a lot of people who'd had hip fractures. And then that sort of led quite nicely into then becoming a fracture liaison nurse, and finally now ending up as one of the specialist nurses with the Royal Osteoporosis Society. So we wanted to kind of start at the beginning, so to take things sort of right back to the day of the injury. And as Celia said in the main session, this is an emergency. It's not a planned procedure. It's unplanned, stressful, painful, difficult time. And we wanted to think about some practical things, and maybe on that day, the most practical thing for a person as a carer or a loved one of the person that's unfortunately had that fall or broken their hip, to think about what you can do on that day. And it's, I guess, providing some emotional support, but practical help in things like getting their medication together, hearing aids, glasses, those kinds of things that will be really important for them to have when they get to hospital. Other things, like for the day after and after the surgery, so a good pair of slippers, a wash bag, and things like that. And because Julie, you mentioned your mum didn't really want or need too much in that very sort of emergency first part.
I remember the day well, and I was sort of rushing around trying to think ahead of the sorts of things that she would need, and I probably overdid it because I ended up on my first visit bringing a lot of it back. I think really for my mum it was medication, eye drops, those sorts of things that even if they would not be needed in hospital, at least the staff there would be able to see what she's taking. Glasses, absolutely important. Hearing aids, yes. Teeth, if they're not wearing them. The ambulance actually went off with blankets and cushions from the house, but I was able to collect those when I visited the ward for the first time. But yeah, it's just really essentials that you need to put in a small bag in the ambulance if possible. And then I suppose the next step really is how long is it before people have their surgery? Well, my mum, she sort of met the criteria in that she had her surgery the day after she fell, but I understand that's not always the case, Viv.
So it's not always possible or feasible that someone goes to surgery the day after their fall. For many people, they may not be medically ready for their surgery, and the doctors will make that decision. So as Celia mentioned in the same session, in the earlier session, they might need help controlling their diabetes, or they may have developed an infection or had an infection that sort of led to the fall. So there are lots of reasons why people don't meet that criteria, but be reassured that the doctors will get your loved one to surgery as soon as is possible and safe for them. We also, in the main session, they talked a bit about length of stay, and they talked about it being quite a short time possibly in hospital. And my experience is that can really vary. It can be quite a short amount of time in the acute, in the emergency wards in the hospital, but then some people do need to go on to a rehabilitation hospital before they go home. And I think it's really important that we reassure everyone that everybody is different, and there is a right or a wrong about how long you spend in that hospital, and it depends quite often on factors outside of your own control. So there are things that might, things like beds being available, or care or help at home being available for when you are it. So the person may be ready to go on to the next step, but might not be able to because of other reasons. And there may be, a few hiccups along the way. You mentioned some things with your own experience, Julie, with your mum's.
Yes, I mean, my mum is 87 and extremely fit and active and well prior to her fall, but she still ended up having a 3-week stay in hospital. 2 weeks of those were on the acute ward, the trauma ward, and then she went to rehab for a week. And although everything went to plan, there were just a few little things which just delay things a little bit. As you say, there's bed availability, which certainly affected my mum, but also things at the beginning. I think Celia talked about the fact that you have a catheter and you have to be able to cope without that. Constipation is a big problem. So all of these little things can just lengthen the stay a little bit. So if you have to stay in hospital for longer than the average, it doesn't mean that you're not a success story, because my mum has done extremely well, but she was 3 weeks in hospital. So yeah.
And we also wanted to touch a little bit on talking about people who may be in hospital who've got dementia, and something that was briefly mentioned in the main session. But if someone who falls and breaks their hip has dementia, you as their carer, it might be good to let the staff know, and they will often ask you as the relative or a carer to fill in something that's called a "This Is Me" document, and it includes simple information like likes and dislikes. Do they have tea or coffee with sugar, or what do they like to be called? What were their interests? What do they normally do on a day-to-day basis? And that can sometimes be really helpful. And as Celia did also mention, that people can unfortunately develop a delirium, so a sort of a temporary sort of new confusion that can be really distressing and upsetting for family members. But it's important as the relative and carer to reassure them and support them and provide that bit of familiarity that they may lacking because of this change that's happened to them. And it may be able to provide, as say, familiar items bringing in that they may help them to have a sense of a norm of normal life. And it's something that your mum found, that these emergency wards can be very busy and loud and
yes.
difficult places to
work. Although mum didn't thankfully have any problems with delirium herself, it was quite obvious that other patients in the ward she was on did. So yeah, you're right, Viv. Night times especially can be very noisy, and people don't get a lot of sleep very often, so people can be quite tired, and obviously they're having to do all of the physio and the OT and all of that sort of input. So yeah, it's just being prepared for that, I think, and trying to get as comfortable as you can to sleep in what can be quite a noisy environment.
Yeah, and your body's getting over a big injury, big assault from not only from the injury, but then the surgery as well. So it's trying to find the time if you can to rest and everything. But you mentioned briefly about other specialities and members of the multidisciplinary team, OTs, physios, etc. So we wanted to talk a bit about who was involved in the discharge and that kind of thing.
Yeah. In Mum's experience, obviously she was in effect discharged from the acute ward over to the rehab. So there was but there was inputs from all sorts of people, discharge coordinators, nurses, occupational therapists, physios, and of course the doctor. And they work together as a team really to assess whether somebody is able and fit enough to move on to the next stage, whether that's to rehab or whether that's to their home. So lots of people, I remember lots of people visited Mum and assessed her and worked with her really to come to the conclusion that was going to be safe and effective for her and for the family.
We thought maybe in this session we would briefly explain some things like what is an occupational therapist. So very briefly, an occupational therapist is someone who works out how you're going to manage those everyday activities more easily and independently, may provide equipment that you might require to be able to get you home safely, and finding new ways to do the things that you did before, but providing you maybe with a bit of equipment or help or ideas on how you can do that. And the physiotherapist, they help you more in looking at ways to improve your physical activity, your movement, making sure you're safe walking around, your environment. But it's quite often that they may come as a team. We may do a bit of, both, and there's a bit of overlap in there. And we wanted also in this session to talk about what happens when someone who has broken their hip, they themselves may have caring responsibility at home. And we thought it was important to make sure that the team that may be looking after the person with the broken hip knows, what they may require, and other responsibilities they may have when going home. And that sort of brings us, I guess, back to your experience, Julia, about, what happened with your.
Yeah, I guess that people's lives are complicated, and it's rare that there isn't other stuff going on in people's lives which are going to be affected by a big traumatic injury like a hip fracture. And in Mum's case, yes, she has some caring responsibilities for my dad. So that was, obviously at the forefront of the family's minds was just, really swooping in quickly and taking over, not only to sort of care for Mum and support her in hospital, but also to make sure that Dad was okay at home and had somebody with him. So yeah, it's never straightforward, and I think all these things need thinking about, and really for the person who's fallen to feel confident that whoever they love at home is safe and well. And I think that will have been at the forefront of Mum's mind when she was in hospital. So we had to be able to reassure her that was all being looked after at home.
Your mum went sort of from the rehab hospital home, but had some additional support. And
as far as I know, that it differs around the country as to what can be offered. But yes, where my mum is, there was a community enablement team who were able to come in and offer some care for the first few weeks after she got home. And I think, obviously the offer is different around the country, but this involved carers coming in twice a day to help Mum get up, and all of the care needs that she had in terms of coping in those early days. And certainly we were very appreciative of that help. I understand it was free for the first few weeks, but I think it could be continued at a charge should we need to it. But some of the other things that I found useful, we talked about OT and occupational therapists. There were a few things that did need sorting out when Mum got home and started to get better, like putting socks on was a big thing. So I found something on Amazon that actually was a little plastic aid, which really helped getting the sock on the affected leg, and really helped her to be more self-sufficient. And she certainly used that with the carers that came for the first couple of weeks, and they showed her how to use it, and that worked really well. So it's those little things that really just help with that independence, which is so important.
I've been looking that up, and as you say, there tends to be some short-term care that's available, as we say, usually up to 6 weeks, but that might be called something different in different parts of the country. It might be, as you say, community enablement or intermediate care or reablement teams. And these are as I say, tend to be short-term, offers of help until, you get back to that level of independence. But in some areas it can be, it might be able to be extended. But this team is usually, as we say, OTs, physios, nurses and carers who may come out to your home to provide you with a bit of support. And we also, I guess, wanted to touch briefly on your experience of being a carer now yourself in that situation of, having to think about work and the consequences for your life, I guess.
Yeah, I think, yes, it has been a bit of a jigsaw between my sister and myself, really making sure that we're offering my parents the best we can. Thankfully, with home working, I'm able to work on, at their dining room table, so I can be here and support them should they need me. So, but it's, obviously not all families have got that luxury. So support for carers is hugely important. And there are organisations, Carers UK, etc., who can offer lots of information for people who find themselves in this situation. Because as we've said, this is a sudden emergency situation which you do not plan for, and you have to think on your feet. So there's lots of help out there to really, make sure that you're tapping into all the services that are available to make, lives easier for people who are caring for people who've broken their hip. So I hope you found that little session useful. Obviously, Viv's got lots of professional experience of dealing with people who've broken their hip, and I hope I've been able to chip in with my personal experience as to what's happened to me and my family over the last few months. So I hope you found it useful, and goodbye from us.